the overall healthcare infrastructure, and to research into epidemiology on the control of health and disease conditions in the defined population. Finally, in this changing world with unique challenges that threaten the health and well being of the population, it is imperative that the government and community collectively rise to the occasion and face these challenges simultaneously, inclusively, and sustainably. Social determinants of health and economic issues must be dealt with consensus on ethical principles, universalism, justice, dignity, security, and human rights. This approach will be a valuable service to humanity in realizing the dream of right to health. The ultimate yardstick for success would be if every Indian, from a remote hamlet in Bihar to the city of Mumbai, experiences the change. Thank you. Now I would like to request Shailja ma'am to give the keynote address.
Friends, is everyone there? They can listen, they can hear me, see me?
Yes, ma'am.
Okay. So I will start with a small introduction after first thanking the principal and caucus and all the young people who've been in touch with me for giving me this opportunity. You may think that I talk at many fora and therefore, this must be something that I do all the time. But I don't get too many opportunities of talking to such young people. So for me, it'll be enormous help if you tell me whether at the end of my talk, what I have said is of relevance to your interests, whether you're sitting for the competitive exams or you're going to do anything else in future, whether in any way you have understood the entire sector, which has to be compressed in a very short time, but I will try and touch on what is most important. Once again, let me thank the principal and every one of you for taking the trouble to have me here. I hope I can meet with your expectations because as college students, I know your attention span will be limited and I will try and make it interesting for you. The way I want to talk to you today is the following. Instead of plunging into a PowerPoint presentation straight away, which I will be leaving with you so you can always access it, share it, do whatever you like with it, and put it in the public domain, I have no objection. Only please attribute it to me. But apart from the PPT, let's talk in a broad way, in a way that, say, a layperson. I know Ishan's presentation showed a lot of depth of understanding of the health sector, but let us presume you are talking to a person in a drawing room and they know nothing about this. Let me share with you what normal perceptions are. Normal perceptions are that health means doctors, facilities, clinics, hospitals, medicine, and getting well and going back to work or going back to school or college. That is not really the totality of health. Health is really which is from your birth to your death, and it is very little of it should really be medicine. Much, much more has to be public health and preventive health. It is not fashionable in our country to talk about public health or preventive health because there are, and I'll be frank with you, I've been part of the sector and I plead guilty. It is very, very intoxicating to listen to arguments given by clinical people, by clinical teachers, medical teachers, and particularly people who are in the super specialty and specialty areas, that if you don't do the following, you will have this problem. With the result that expenditure on tertiary care, which is your high-end super specialty hospitals, and then on everything to do with high-end care of somebody who is sick and needs treatment, overrides the question, why should so many million people be getting sick anyhow? Are we judging ourselves by how many people are getting diabetes, hypertension, cancer, malaria? Are we really in a position to say that we did everything to prevent it as a society, as a government, as individuals? Or did we allow all this to land without any awareness as to what was happening. And then suddenly we are forced to go to hospitals and doctors. I think this is what is happening. And this is the real, you might say, challenge which the health policy must confront. The health policy 2017 has confronted this. It is not as though it's not there in black and white. In a very, very, you might say, persuasive way, it has done it. But somehow the interests of groups which are more interested in medicine than in public health, preventive health, primary health, have overtaken the voices. I'll give you one example and you will understand immediately. When I was in the Ministry of Health, and I've been in and out of that ministry for about 15 years, even after retirement, holding some position or the other, I do remember I was a fairly young officer, and the minister sent for me and said, we have been sitting on this matter for 16 years for setting up a trauma center in AIIMS. And why are we not doing it? And you are the joint secretary in charge, and why have you not moved this file? I said, sir, I wasn't even aware that there was such a file. I'll certainly look into it. But, and that was the mistake I made, I said, but sir, you know, all health policies say that in a poor country, a trauma center will save maybe 2,500 lives in a year. Not even that, 200 lives is more like it, saving lives. Whereas millions are dying because they don't have access to primary health. They don't know how to take care of themselves from childhood to death to prevent the onset of disease. And if we put the money that we will put into this, into that, it would give you returns which will affect tens of thousands, hundreds of thousands, even millions. I was definitely not listened to with any great, I would say, nobody was interested in what I had to say. And I was told to get the file moving and not waste any more time on it. The example is only to tell you that clinical care, and I'm not against it, as the principal said, we have medical tourism in our country because we have high-end hospitals, because we have super specialists, because we have the highest, you might say, level of equipment and diagnostics comparable to any country in the world. And we save a lot of foreign exchange by not having to send people to foreign countries for so many operations which are needed by them. Those are the plus points. But while not deprecating those achievements, I must say that there is a difference between medical service and public health and preventive health. And as I said at the beginning, public health and preventive health is what will prevent you in large numbers succumbing to things which are preventable. Malaria is one of them, tuberculosis is one of them. These are diseases which are communicable. You also have non-communicable diseases like diabetes, hypertension, cancer, obesity. All these things are very largely, the NCDs as they are called, are very largely the result of lifestyle. And if we do not invest in preventive health, which is to insist on checkups, to insist on screening populations early, to insist right through school and through college and otherwise, not through curriculums, but certainly through some sort of communication platforms, that by having tobacco, this is what you're going to bring on, oral cancer. By having sugary drinks, salt, a lot of salt, we all think that all these things are tasty. We've all enjoyed them. And let me not put down people who have chips and who have plenty of salty chaat and things like that. But if it is overdone, I'm not talking about normal life, I'm talking about overdone situations, you get very quickly into the diabetes syndrome, into the hypertension syndrome, and obesity sets in, which has many problems. So to come back, I'm trying to tell you that preventive health could take care of many of these lifestyle diseases. As far as communicable diseases are concerned, if you don't have surveillance, And that is key. And that is what public health is about. Having people who know about insects, who know about animals, who know about quality of water, who know about public health engineering, when the pipes which are delivering clean drinking water are getting mixed up with sewage. These are things which are the job of public health engineers and public health personnel. India did very well in the 1950s and 60s, and we were able to reduce the malaria enormously. We were able to eradicate smallpox. We have been able to overcome polio. These are not small achievements for a country of our size. Remember that Tamil Nadu, just one state, is the size of France. And Germany is the population of Germany is the same as that of Bihar. The population of Uttar Pradesh is that of Brazil. We're not talking about small places, we're talking about countries. To achieve this in countries of our size is enormous. It is absolutely mind-boggling how it was done. It only shows that we do have the capacity, but we also do not have the capacity to be able to go down and stop things before they happen. That is why you have horror stories of some encephalitis, children dying, all kinds of things happening, an epidemic here, an outbreak there. I'll come to COVID later because that is something which is the here and the now, and I think that's important, but you must have the background first. So I have tried to distinguish, to tell you the difference between public health and why it matters so much, and it has been badly neglected. Posts are not filled up by state governments. The health policy talked of having a public health cadre. No such cadre has happened. The public health, the health policy wanted people with backgrounds which are as dissimilar as having public health qualifications, to being social scientists, to being economists, to being almost every single, you might say, background, to be inducted to join the cadres for public health. That has not happened. The states have not invested in it, and the center has not pushed it. So on the side of public health, we are very weak, and COVID is one example. It can become 100 things. We've had dengue in the past, which is not as, you might say, transmittable in the way it is transmitted by a mosquito, whereas this is transmitted by droplets which you cannot see and which you cannot put odomos on. So to bring it back and pull back what I'm trying to say, this background is very important. If you know this background, the difference between preventive health, as I told you, so many of your non-communicable diseases can be prevented. But when you have families who in their 20s, 30s eat any amount of pakoras, have any amount of soft drinks, children are told, also to Coca-Cola bahut pasand hai. These are absolutely lethal and are being propagated by companies, and we are not doing anything to prevent it and to ring the alarm bells for mothers and fathers on this issue. I just wanted to give you this background so you understand why on the NCD front and the communicable front, communicable diseases being like malaria, leprosy, TB, these are all communicable. We have not given it the primacy it deserves. And our structures are very weak. For instance, we have these primary health centers, about 25,000 of them in the country. We have the sub-centers, which are really not very functional except for the antenatal care and that kind of thing. They do not dispense medication. So you have a third thing happening, which is even worse. And I'll be happy if you look at a report which I wrote. Shivnada University gave me a fellowship and said, can you hear me? Can you hear me?
Yes, ma'am, we can hear you. Yes, ma'am.
Shivnada University gave me the fellowship, and I wrote a report on unqualified medical practitioners in India, the legal, medical, and social determinants of their practice. And I did this because I had studied everything there was to study in health, but never looked at this dimension. And I went to Professor Anand Krishnan in AIIMS and I said, will you guide my research? And he did. And I went off to a district I won't mention, and I actually did field work with these. I mean, I got to go between to help me to access the RMPs, the Jhola Chap doctors, the informal doctors, the informal providers, all the things that people, the words people use. We all know who we mean. And my eyes opened because there are more RMPs in India than there are doctors. And how do we know that? We know that because the census was unraveled by WHO Geneva, which was given access by the erstwhile Planning Commission to all this data. So they went back to what people say their occupation is, and each one said they are doing medical care. But when you looked at their qualifications, the qualifications were 10th pass or 12th pass. So when you see that, I tried to see what these RMPs were doing, and they were giving steroid injections. They were giving IV fluids for just something which nobody had diagnosed even. Antibiotics were given at the rate of just, 3 or 4, and if you get well, fine. If you don't get well, come back, kind of thing, without any authority to be doing all that, illegal as it is. There's no use saying it is a problem of this state or that state. It is happening countrywide, and it's been happening for 20, 30 years. And my research pointed to the fact that poor people, which is in rural areas, there are about 2 RMPs in every village. In urban areas, in the slums, there are 6 or 7 of them in clusters within the slums. I have talked to these people, whether they are laborers, construction laborers, they all say we go there. So they would prefer to get a steroid injection, pay 50 rupees for that one injection to be able to save their dhari, their daily wage, and be able to go back to work the next day, because that is more important than anything for that time. That 400, 500 is absolutely important to run the next day for food, for children, for many things. So given this situation, we have 2 or 3 things happening. Primary health centers, which are only serving about 20% of India. People don't go there. They're too far. They are not manned by doctors most of the time. Doctors don't go there. You have sub-centers which don't dispense any medicine because only doctors under the law can give medication. So you go to an RMP, that is the Chola Chap, and if things go wrong, the RMP takes you to a proper private practitioner who is in the, you might say, periphery of a township. So they take the patient on a scooter and say, okay, we'll negotiate the fees. If the private doctor says, I'll take 200 rupees, this man on behalf of his client will say, nahi saab, ye bahut bichare hai, poor hai, unko to 100 rupees mein kara do. So the doctor will give him something and probably things will move on. Now, when you talk of Ayushman Bharat, and I'm jumping the gun by talking because it's important, Ayushman Bharat is a brilliant way of taking care of those who need hospitalization. If a poor person's family needs hospitalization, operations, any medical care in a hospital, Ayushman Bharat will insure you against that, which is great. Not you, but people who are at a certain threshold financially. However, what about this day-to-day? Khansi ho gaya, zukam ho gaya, pet mein dard hai, diarrhea hai, घुटने में दर्द है, सांस चढ़ रही है. All these things have no doctors available in rural areas. Doctors being people with a medical qualification. And in urban areas, the slum people say we cannot afford to go and stand at your Arya Samaj dispensary, your Chinmaya Mission dispensary, your government dispensary, because we lose half a day's wages. So we'd rather go to the Jhola Chap who will do it for you immediately. That is where the concept of Mohalla Clinic has worked, because it has replaced the RMPs, and probably that is the answer for urban India to have that kind of a structure. I won't go into the details of that, but this is to tell you what happens between public health, medical care, and the availability of the doctor. If you're clear about that, I will now move on to a small presentation which will give you the context in which I want to tell you about important things. It's not possible to cover everything, but I think you are knowledgeable people. You are obviously interested in the subject, and I'll be happy if you just see the presentation. I'll run you through it. Aditya, you have to take me, it's not Aditya, sorry, it is, who will take me to my share screen? Yes, I've shared screen, I've opened my PPT. Can you see it?
No, ma'am, we cannot.
Okay, I've done share.
Yeah.
Can you see it now?
Yes, ma'am. Yes, ma'am. We can see it.
Okay, so I'm starting with number 1. And don't worry, I'm going to do more talking, so you don't have to read it. This is available to you. Don't bother to take notes. Not everything there is cast in stone. It is more to help you. So I'm starting with the first, the topic given to me was Health Policy of India, Challenges and the Way Ahead. And the structure will be, as I've covered most of this already, understanding the differences between public health and medical service, and between primary, secondary, and tertiary care. For those who have not understood, primary means at the lowest level when you just need to be guided what you should do for a particular condition that you have, which is not serious, but you need to get well. Secondary is when you need a hospital, which is like a district hospital or a nursing home or something, which can be attended to and is not something which is an emergency, but definitely needs care. And tertiary is like your All India Institute, your Apollo, your Max hospitals, your all those hospitals. That's as far as that goes. Sorry, I've gone. Now, in all this, nothing will work without financial security. The health sector needs financial security for doing all these things properly. If you only focus on, say, tertiary care, you'll take away from primary and secondary care. If you focus only on medical service, you'll take away from public health. So you'll have diarrhea, you'll have all kinds of other problems, and the dengues and the malarias all cropping up. And they affect millions of people, not thousands or hundreds. The second is that, as Ishan said in his presentation, a country's progress is determined by certain key indicators. And probably maternal mortality and infant mortality are two of the most important indicators of a country's health status. The National Health Policy 2017 wanted to reduce maternal mortality ratio in India. Its ratio is how many people, how many women as compared to a lakh population. So it was in 2017, 122. And by 2020, they wanted to reduce it to 100. That has not happened. And India is vast. You really cannot say anything about India without looking at the states, because there's so much difference between states. So without going into too much detail, just to tell you, our best performing state, Kerala, has a maternal mortality ratio of 46 for a lakh population, whereas UP has 201 for a lakh population. That speaks for itself, and we are far away at the moment from reaching the 2020 target, but let's hope by 2022-23 it'll be achieved. The next slide is about reducing infant mortality. Infant mortality, as you know, is within a year if a child after being born dies. From the day it is born, it is considered an infant mortality. And it is a very, very important indicator of the status given to health and the status of health of a country. Now, it is the number of babies below 1 year dying out of 1,000 born alive. So in India, the IMR is 33 at the moment. IMR for European region, for the European region is 8. But Sri Lanka also has 8. So it is not as though only rich countries can achieve it. Even Bhutan, Bangladesh, and Nepal have less than our IMR. And Kerala and Tamil Nadu have always, from the 1989-90, had a very low IMR because of very great focus given to health. Both these states have always done it. And Kerala and Tamil Nadu have an IMR of 10 and 16. So remember, we are 33 all India. Kerala and Tamil Nadu are 10 and 16. Whereas our worst performing states are Odisha and UP, and they have an IMR as high as 41. As statistics go, it may sound to you as what is that? But it's a very, very potent way of understanding. If you don't care for your mothers and your children, you can't be caring for anything else. So that is important and must be borne in mind. Now, in India, the expenditure, as I told you, on preventive healthcare is very low. I was also, you might say, a victim of very, very persuasive talk given by clinical experts who will always make out that something is really earth-shakingly important, and they're very articulate people. So I mean bureaucrats tend to tell ministers. Ministers are also lobbied upon by various people who have their own interests in the procurement of equipment, their own interest in pushing a certain lobby, and with the result that you think preventive है, वो तो सब जानते हैं, वो तो सब जानते हैं, वो तो hygiene की बात है, वो तो उसमें बड़ी बात नहीं है. Whereas it is key to preventing ill health. So in India, we spend on curative care, which is hospitals and doctors, 52%, on pharmaceuticals and drugs, medical goods, 29%, patient transport, laboratory, imaging, governance, administration costs about 11%, and preventive care is just 6.8%. So most non-communicable diseases are caused by unhealthy lifestyles. Greater focus is needed on lowering the intake of sugar, salt, fat, because they are the ones which cause all these non-communicable. They start all this. Some of it is genetic, and therefore I'm not blaming everybody who gets these problems as being blameworthy. They have never probably enjoyed sugar or salt in the measure that many people do. But they get it because of genetic problems and other, you might say, environmental related issues. But if you just talk about things you bring on to yourself, well, sugar, salt, and fat are absolutely, I would say, crucial. And if you go to some countries, like, say, when I was in Toronto, I was amazed. A slice of just a piece of pizza, they will write 700 calories. And your daily intake is supposed to be 2,000 calories. So if one slice is 700, what are you left with for the rest of the day? So that is the importance that is accorded to this for being able to tell people, make them aware. They have very clear warnings about trans fat, which is there in the pastry or in the biscuit or whatever. Promoting exercise. We are all, as you are young people, I'm sure you have already taken exercise very seriously. But in my generation, nobody took exercise seriously. It was just considered as, time kahan hai ye sab karne ko? मैं walk के लिए मैं जाती हूँ ना, 20 मिनट तो मैं walk करके आती हूँ, which is not enough. Your entire, cardiovascular system has to get geared up, whatever age it is, and it is not being done and is not being pushed enough. Yes, we have many programs now pushing yoga and pushing sports, but the understanding in every family that everyone in the family needs to exercise a lot, enough that you start sweating, that is needed by your body, is not understood and is not pushed. And controlling alcohol and stopping tobacco is one sure shot way of taking care of a lot of things. But I won't get into lectures on that. This is not a discussion on alcohol and tobacco. Now, the other area, apart from maternal mortality and infant mortality and all that, which is extremely important, is population stabilization. There is good news and bad news. The good news is that India has almost reached that magic figure of 2.1, which is a statistic. But every woman in her reproductive years, if she produces 2.1 children, then it can be said that each of the parents is being replaced by two people. That is ideal. And we were in 4 and 3 and God knows what, but we have reached 2.2 in 2017. That is the latest figures that are available, because this is not something that is computed every day. It is done over 3-4 years. So 2.2 is not bad at all. But the part which is remarkable is that most states in India have actually reached 1.8. Kerala and even West Bengal, I mean, they have the, you might say, fertility of European countries. It's unbelievable. When I told this to people, they said, it can't be. It is. People have accepted family planning and they've kept their children, their families very small, so small that now there is a fear that we are going to age, as has started happening in Kerala, and you may not have enough young people to be able to take care of old people. That can also happen. But you still haven't got over the old momentum of large population, which continues in Bihar and UP, which is having still 3.2 and 3.1, as my slide shows you. The health policy had a goal of increasing the proportion of, now, in this, family planning is key. And whereas countries like Indonesia, even Iran, Sri Lanka, Bangladesh invested very early on in giving women access to stable contraception, India went the route of, oh, batte hone do, uske baad sterilize karenge. Now, we are the only country which has such a lot of female sterilization. And when other countries have invested in implants, injectables, IUDs, and been able to control their population 20 years ago, in the 1980s, Indonesia had done so well. And we are still now grappling, which is bad, because if a woman does not have control over her own reproduction, ability, and she's just forced into an unwanted pregnancy time and time again, she loses her health, she can never stay rooted to any kind of education, and she becomes just another piece of, just another human being who is looking after cattle or is minding children or cooking. She has absolutely no empowerment. And that cannot come unless she has small children, a smaller family to look after and nourishment for herself and her children. So the good news is, as I told you, that population stabilization has begun to come. The bad news is that we still have a long way to go, because the most populous states are still way behind what they should have been. Third, that the momentum, the past momentum, after all, people may be having family planning, but they cannot stop every couple from having at least 2 children. You cannot just say now, because of our 7 and 8 children, we'll stop everybody from having any children or have 1 child. We're not China. With that, the momentum will go on, because the base is so large that you will not be able to stop it. So you might say, the evening out, the plateauing out will actually happen in 2050. And I'm putting a optimistic figure of 2050 because of this past momentum. And that is why it is very, very important that whichever children come into the world, come into our states, at least they have good nourishment and a chance of leading healthy lives and are not compromised from birth. So that is the focus that is needed, and which is not getting any primacy from most of the northern states. It is getting a lot of primacy from southern states and a little bit Maharashtra also and some western states, but not as much as needed. So that is as far as population stabilization. Now I'm coming to, I've finished about, according to, I started at 11:26, it's now 12:08. I'll go into COVID now and then open it up for questions. Now, COVID management is something which is part of that communicable diseases syndrome. It came through, let us say, a bat, it came through a pangolin or whatever animal it was in China. It entered somebody's system, and that flared up in Wuhan, and slowly it flared up in other countries and slowly percolated into the populations of those countries, including India. It started as a zoonotic problem, which is to do with something to do with animals. Now, how it started is not something which I'm an expert to discuss, and nor is it something which concerns us. What concerns us is it was a pandemic and it was going to spread into the whole population. Why is it that it became so dangerous? It is because, to be very honest, it was going to affect you and me. It was not going to only affect the poor. Tuberculosis largely affects only the poor. HIV/AIDS is something which is controllable by changing lifestyle, and HIV/AIDS, which I manage, which seemed to be impossible, has been not eradicated, but and has been controlled simply because the target groups, which were truck drivers, used to go, sort of indulge in unsafe sex when they stopped here and there. Sex workers, because that is their job, and they will be accessed no matter what you do, and you cannot wish it away. The third were intravenous drug users. These three were the ones which were more susceptible to get HIV/AIDS because it is spread through body fluids. We were able to, we meaning I was in the ministry then, and many of my predecessors and successors, we focused on these three groups and we went hammer and tongs. I've been to red light areas, I've talked to the sex workers, I've talked to men having sex with men, all kinds of people. And you had to be absolutely without any judgment. You had to say, this has to be tackled. And that is where NGOs were extremely useful. They were able to use the language that should be used, and it was able to be controlled, including truck drivers, including intravenous drug users. In COVID, it is not the same thing. COVID is something which goes from particles out of your droplets. It could be just anybody. It need not happen. It can happen. The man who comes to your house to probably cook your food or something, he may be a carrier and he would not know it. You would not know it, but he can sneeze and you can get it. So these are things which are worrying everybody in India because it's not restricted to the slums. It is not restricted to congested areas. It is restricted to no one, anywhere. Anyone can get it. And it is scary because it percolates and affects your organs. And if you need care, young people get over it mostly if they get timely care, but old people don't. And we do value old people in our country. So it is a dangerous thing. Now, what happened? What did India do? It is a devastating public health emergency and probably the worst in the last century after the Spanish flu. It is making countries around the world take a hard look at their own health systems. And that is where public health will come in. That is where all these things of keeping surveillance will become very important from now on. And if they don't become important, we can have many more COVID type of disasters. And they can start from India. They don't have to come from China. India did extremely well by clamping down on international flights very early on by having a countrywide lockdown from 24th of March. That the lockdown was implemented by 30 states and by 1.3 billion citizens without a murmur, it is almost a miracle because we are considered the most argumentative societies in the world. But what happened subsequently has upset my calculations and created many other kinds of problems. And that's not the subject of my talk, but it is something I'm deeply interested in. Why did the migrant crisis start? It is, in passing, I want to say that COVID is a disease, but this is a disease of ignoring poor people for too long. We have a plethora of laws which makes it incumbent on every contractor to take care of the health of the migrant, these construction laborers. Construction laborers are almost 20 to 40% of all these migrant people. They live hand to mouth day to day. The law requires that construction laborers, if you employ more than 10, you have to take care of certain things. Written in many laws. I won't go into them, but there are at least 5 laws. None of these were ever implemented, never overseen by state governments, never really made into a priority, whether by members of parliament, whether by media, by anybody. So we just had this attitude of, slum mein jaane do, kaam to ho raha hai na. This is where we went terribly wrong. These people were willing to listen to your lockdown for a month or so, but when they had nothing to eat, they were humiliated, they were thrown out of their houses. And eating doesn't just mean filling your belly for the minute. It is the humiliation that you have to face, standing in a queue, standing like beggars, waiting for your turn, getting not enough food for your children at home because they say, "Hum to ek aadmi ka de rahe hain, pure parivar ka thodi de rahe hain," that kind of thing. So, with this kind of a background, we have now got a completely new problem, which is going to become a health problem. Because if you don't cater to these people, there will be more and more of this slum dwelling, this congested dwelling. And then, like Dharavi, and you've heard about the slums, I hope it's not going to happen in Delhi, but certainly it has happened in Dharavi, where the fatality rates are extremely high. You cannot get people to wear masks and to keep social distancing. It's not possible. So, coming back to COVID, now, more than 2/3 of India, at 67%, still lives in hundreds of thousands of villages in 730 districts in India. So when we talk of India, it is not Delhi and Mumbai. Delhi has a population of 20 million. Maybe Mumbai has 18 or 19 million, maybe 20 also. Of that, if you look at Delhi, Delhi's slum population is about 2 million. The unauthorized colonies is about 8 million, 7 or 8 million. The rest is urban villages, and the rest is people like you and me. Now, that is an urban phenomena because work is available here, minimum wages are the highest here, facilities are much better here, so people gravitate here, but they gravitate to many other towns. But 67% live in the districts, and we cannot talk of India without thinking of the districts. So one thing is there that districts are 730 and they have varying populations. Some districts have a population of about 11 million. That is the size of Belgium. Some have a population of 2 million. So you cannot really say everything is the same, but you have 730 districts. And the lockdown did something great. It gave time for the health secretaries of every state who were getting instructions from the health ministry to be able to put their systems at the district level in order. So you were able to have quarantining, isolation, requisitioning beds, taking beds from dharamshalas, from hotels, from resorts, and keeping this preparation ready. And you were also had tremendous authority given by the Disaster Management Act, given to the district magistrates, to the chief secretaries, and that came in very useful. And one of the earliest examples I still remember, in around March, I read this article, India's New Italy, Bhilwara in Rajasthan. I looked it up and I did find that Bhilwara was having cases and deaths very early on. And the remarkable part is that the district magistrate, I still remember his name, Rajendra Bhatt, I talked to him, and you should get him to tell you on one of your caucuses, how did they manage containment of COVID in Bhilwara, because that has now become the Bhilwara model. Kasargod also did extremely well, but then everything that that state does is so good. But Bhilwara is Rajasthan, which is not known for its health prowess. But Bhilwara is a great example, and I suggest that you should look up Bhilwara and see how it was done. And that is the gold standard for 730 districts, which may not be doing as well as Bhilwara, but certainly when the migrants go back, they are in a position at least to know what is to be done. They're not at that stage when they'll say, "Pata nahi kya ho raha hai, hame malum hi nahi karna kya hai." They know very well, which is the biggest advantage of that lockdown. Now, in India, we have done, in terms of deaths so far, I have figures up till the 25th of May, not up to today, unfortunately, but let's say that you can add some to that. But we have had far fewer deaths as compared to other countries in the world. And this lockdown has slowed the spread of contagion and allowed the health systems to gear themselves up, which is a very, very important part of the management. Now, if you look at this graph, I don't know whether you'll be able to see it. Can you make out what is written? I don't know if I can blow it up.
Ma'am, we can see what is there. Yeah.
You can see it?
Yes, ma'am, it's visible.
Okay, then I won't bother. No, I can't blow it up. So you can see at the top is India, and this is the blue dot is May the 15th, and the red dots are May the 25th. The first red dot is May 20th, and the second May dot is May 25th. You can see where India is in terms of the death. This is COVID deaths in selected countries from May the 15th. So when you look at India, it is here. And when you look at the rest of the world, you can see this graph. And I'll read out from the bottom. Let's take a country like Spain is second last. United Kingdom is third last. Italy is fourth last. France is fifth last. US is here where my cursor is. And these are the rest of the countries I won't bother you with. But India is here and China is here. So in a way, the number of deaths that have taken place, considering our population so far as a proportion, are less. What is worrying is that the numbers of cases are going up exponentially. And if they recover, that's okay. If it passes off as something which they got but did not really get into serious trouble, that's okay. Herd immunity will settle. But if this leads to massive deaths, massive need for ventilators, beds, hospitals, doctors, we may have a real problem. We don't know. Nobody can say right now. I certainly won't be able to hazard a guess. Now, when we come to private healthcare, 80% of the healthcare in the country is private. And it is totally unregulated. And I think for years I have been hammering this point that you must have a regulator. You have it for telecommunications. You have it for electricity. When healthcare, health industry, it's treated as an industry. They can get foreign direct investment also. They are companies. They should have a regulator because otherwise they're doing things which are causing a lot of, you might say, unfairness to the Indian public. And there it could be the middle class Indian public, not the poorest of the poor who can't afford to go to these hospitals. This I will just quickly run through. It's in front of you. The response from the private sector to COVID has not been very remarkable from what we hear. There have been reports of massive overcharging with rates in Mumbai by certain private hospitals coming up to 1 lakh rupees per day for a COVID patient. Many private hospitals just shut down, saying that we're not going to manage it, which is an easy way of getting a license, getting registration, and then just saying we're not in it anymore because we don't. What would happen if your bank just closed down? It's as bad as that. This is highlighted by the unregulated markets. Invariably, they fail because if you leave everything to market forces, people will only think of profit. That is human nature. And they are businesses. They are not there for altruism. The regulation of private hospitals has been on the back burner for 8 years. Government had brought in 2010 a model act called the Clinical Establishments Act, saying you will have to register yourself to say that you are going to do, how many people do you, employ? What are the qualifications of the people you employ? Are you doing only maternal care or maternity services? Are you doing specialty services? Are you doing surgery? What are you doing? You should be able to say that on a website. And you should say who is working for you and what are the qualifications of the doctors. There was completely a no-no from the Indian Medical Association. Nobody wanted it. Why? Because most of them take people who are unqualified, who later become your Jhola Chhap and your RMPs. They take them just like we take a boy who works in your house as a odd boy doing everything. He slowly learns to make chapatis, to make food. Well, exactly the same way, without knowing anything about anatomy or physiology or biochemistry, they just learn कि ये injection देने से ये आदमी ठीक हो जाता है. So these are the people who are employed, and people who may not have qualifications are doing procedures which they should not be doing in the smaller places. In the larger places, people are not sharing this data about the people they employ, what exactly they are charging patients for, what are the bills going for, why are so many tests necessary. None of this is being regulated by anyone. There's no comparison, no requirement even to put up data, which is very, very serious when this is 80% of your health sector. The regulation of the private sector is important. As we move on, it is important that comprehensive regulatory measures which have to come into place, and they are resisted very strongly by influential private sector lobbies. But this, if you ask me what is a challenge after COVID, this is a very big challenge. It has to be confronted. And concerns over overcharging, problematic quality of care, unnecessary procedures, all have to be confronted through data collection, data collation, and definitely calling out to those who are slipping below the benchmarks prescribed. I'll go on to probably what is why is private sector regulation needed? Because we have encouraged private sector to run as an industry, where industry's entire ethos is profit maximization. During the epidemic, it is clear that commercial private players cannot be left to market forces. There is hardly any legal framework to ensure that their obligations are enforced. And emergency measures like requisitioning private hospitals show that the state can exercise its authority to get private hospitals, but that is because this is treated as a disaster. Tomorrow, it can still be needed without bringing in the Disaster Act. So without having that authority, how are you going to do it tomorrow if it's not COVID, but the younger brother of COVID? They should definitely, those who have got concessions, customs duty exemptions, land at concessional rates, land free of cost, they must work for the poor, and that is not happening. I'll share with you that I was health secretary in Delhi in the 90s, and I know I was on the board of 2 private hospitals as the government member because they had got land free of at 5,000 rupees an acre. And I was raising this issue that you're not doing what you said you would do, which is 25% of your outpatient and 10% of your inpatient free. And they just looked at me and said, "What are you talking about?" And I was dismissed. I remember I went in my ramshackle ambassador card. I wasn't even allowed to enter the lobbies of those massive 5-star hospitals. Be that as it may, it is something which is very serious and is being overlooked. The National Health Policy 2017 had envisaged the creation of a public health management cadre in all states, and it did feel that the recruitment should attract young and talented multidisciplinary professionals. Medical and health professionals would form the major part, but professionals coming from diverse backgrounds such as sociology, economics, anthropology, nursing, hospital management, communications. Once they have undergone a public health management training, they should also form part of these cadres. And the policy recognized the need to continuously nurture certain specialized skills like entomology, that is studying insects, housekeeping, biomedical waste management, biomedical engineering, communication skills, management of call centers, and even ambulance services. All this was part of the public health cadre that the Health Policy 17 had envisaged. It hasn't happened even remotely in any of the states. Now, I'm coming to the last 2 slides. The last but one is the need for public health outreach to improve. Kerala has done extremely well during COVID, and they've done extremely well, full stop. In anything they touch on the health or education front, they always fly the flag. Why? Because they have invested very early on in their local self-government, what they call in urban bodies, the elected people, and in rural areas, the panchayats. And they don't just pay lip service, they allow them to plan, they allow them to say at the grassroots, what do you want? What is the gap? How is it to be filled? And that is why when COVID came, they were able to immediately tap these community workers. And they're not workers, they're people who are from the community who have a stake. They're like your resident welfare associations. I know they've all got a bad name for behaving like the second police force, but let's forget that. Otherwise, when garbage is not collected, when trees are not pruned, when there are fights over parking, when the parks are not maintained, it is your resident welfare association which is complaining to the power company, the street lights are not working, the parks are, the mali is not coming. That is the kind of micro level management which local communities do. You need that all the time in public health. And they had it in the NRHM, they had village level committees, but all of them are not working with the kind of mission and passion that is needed. I think COVID requires that that is all resurrected and not treated as a government program. It's not when you get unwell that things go wrong. When you see something dirty and unhygienic, as the principal said, hygiene, sanitation, that is basic to healthcare. When you see that happening, nobody from the health ministry is going to come. You have to be able to tackle it locally. And to tackle it locally, people have to be involved and say, ये तुम्हारा गंदगी है, बंद करो नहीं तो हम ये करेंगे, वो करेंगे. Nobody is doing that. You can't bring police and municipal workers to be able to bully people all the time. It has to be owned by us. We own our homes. We own our neighborhoods. You'll have to learn that. That's going to be a very big problem post-COVID. And I don't think that governments are thinking seriously about how important that is. Even in the slums, it is very important. There are camps within the slums. Who is in charge of that camp? Who is stopping open defecation into the drains? Who is, going to look at the fact that people are creating unhygienic conditions and to pull them up for that within the community? Last of all, COVID is a middle class crisis. All our other problems were of the working class. And therefore, we had this cavalier attitude. And insurance we can go to Apollo. My father will pay to take me to whatever. That's not what health is all about. Prevention, promotion, primary health, having family doctors, being aware of your own body and being able to respond in time. Right from babyhood upwards, the mother must know, the grandmother, yes, even if she gives Ayush medication, even if you take Ayush medication, there's nothing wrong with that for building your immunity. For many other things, I have been Secretary Ayush, and I will definitely say for certain things, it's of great importance, great relevance. But whatever it is, if this is not in your mind as extremely important for everything you do, extremely important for your life, for the children you're going to have, for the generations you're going to build, it will never become a people's movement. And I want to say that this is probably social cohesion will have to be centered around medical and public health. And I don't know how it's going to happen, but there has to be an uprising. I don't mean rioting. I don't mean people doing processions. But there must be within your community, in your home, in your college, in your university, in larger areas, a realization that we are allowing people to trample on our health. And anyone who does that is to be held responsible and dealt with. You cannot wait all the time. The government karega. We just don't have the resources for that. We'll have to think on our feet. Thank you for really listening to me so patiently. I really don't know how many people have participated, but I've enjoyed talking to you. And now I'm free for any questions you want to ask. Thank you.
Thank you very much, ma'am, for the absolutely brilliant address. We are awed by the display of the facts and analysis that you have presented. To give the audience a benefit of repetition, I would just briefly sketch over the aspects that ma'am has talked about in her speech. Well, ma'am began with the primary distinction between public health and preventive health and the importance that preventive health has. Nevertheless, the fact that it has been badly neglected, which has been displayed by the absence of a public health cadre in the National Health Policy of 2017. Then, ma'am talked about the deficiencies of Ayushman Bharat scheme, which though it serves inpatient care very well, nevertheless continues to falter on the outpatient care, where mohalla clinics are here to fill the gap. Then, ma'am went on to dwell on the different types of hospital care, which is primary, secondary, and tertiary. And then, ma'am talked about the need for population stabilization by drawing on statistics, including maternal mortality rate, infant mortality rate, the importance of exercise, and the prevention of tobacco and alcohol to help the public health cause. Also, then ma'am talked about the COVID-19 pandemic and the fact that why COVID-19 could not be limited, unlike tuberculosis and HIV, the role of NGOs in limiting tuberculosis and HIV, and how COVID crisis has spawned into a larger economic crisis, which also included migrant movement. And then ma'am went on to discuss on the idea of a Bhilwara model, where though two-thirds of our residents, two-thirds of our population is engaged and is inhabited in villages, our district administration has been caught off during COVID crisis. And then ma'am talked about the necessity for establishing a regulator of public health for private hospitals, because the private hospitals have been demanding exorbitant prices. They have been shutting their doors on patients during this pandemic, and also the presence of unqualified doctors who continue to serve public cause. Also, the need for also ma'am spoke on the need for regulation of private health improvement. And finally, ma'am talked about the need for a public outreach, the improvement of public outreach, and talked about the Kerala model, where local bodies have strengthened themselves in order to sustain public health. Also, ma'am finally ended on the subject of social cohesion with public health and medical health cause. Thank you, ma'am. And now we would be moving into a question and answer session. I would like to throw open the chat box for questions. The audience is requested to type in their questions and send them on the chat box. Also, whoever is hearing from us and watching us via live streams in YouTube and Facebook are requested to send in their questions via the chat boxes in there, so that the webmaster can transfer those questions into the Zoom chat box. Ma'am, the questions are of three types: the moderator questions, the preset questions, which we've outsourced from a Google form that has been circulated, and finally, the audience questions who are with us currently. I would like to call upon my co moderator, Ria, for the first moderator question. Ria, the floor is yours.
Thank you, Aditya, for recognizing me. Ma'am, as you also correctly mentioned in your address, that how public health and public hospitals are not sufficient enough. And also, it is common knowledge that most of the facilities and medical facilities which are provided by the private hospitals are of good quality, but the prices which they charge are extremely high, which make them highly inaccessible for the majority of Indian population, which is largely poor. So, is it time that our government step into the private hospital arena and put on some restrictions and caps on the prices for the medical facilities? Because even in countries like Japan, they have such facilities. And even if we agree on this, how much our governments are ready to do this and to step into the private hospital arena?
Should I reply straight away, or you want to say reply?
Ma'am, for the moderator questions, we expect you to reply to every question, whereas in the audience questions, we can take a bunch of questions and then you can reply to them.
This was a moderator question.
This is a moderator question, ma'am.
Thank you, Riyad, for that question. It's an important question which has worried me, because when you say, shouldn't governments step in? Of course, the governments must step in. But there is a thin dividing line between private enterprise and being in control and preventing people from doing something which is individualistic. So I can only say that there are many ways in which it can be done. You can certainly have a requirement that you will publish your prices. You say what you're going to charge. You can have a brilliant way, which some hospitals abroad do it. They tell you as you enter that your bill is going to be, unless something new is found, but after your first examination, your bill will probably be in the region of X or Y or whatever. So you know that you will have to pay 2 lakhs of rupees for this particular, you might say, intervention in the hospital. In that way, you're not taken for a ride where you suddenly come thinking you will pay 2 lakhs, but you suddenly charge 10 lakhs. So that is one way. The other way is to put out in the public domain what are your charges for high end surgeries and for high end diagnostics. For instance, the cost of an MRI. The cost of an MRI may be 5,000, maybe 10,000. So be it. Write it down. Let people at least know in advance. If they want to pay, they'll pay. It is a business and you can't cap it. You can't, I don't think it's quite right to say cap it at 2,000 because the minute you can do it maybe for COVID tests because it's an emergency, but you can't do it for hundreds and thousands of procedures which hospitals carry out. I would just say once you put it out that these are the procedures we do, this is what it's going to cost, this is the per day cost for this room, this is what is going to the surgeon's consultation, this is for actual surgery, and people are prepared, they can mentally calculate. I don't think you can cap it exactly because you can only say that, for instance, now procedures. We all feel that they have unnecessary procedures. You go to a government hospitals, they don't ask you to do 20 tests. You go to a private hospital, you're asked to do 40 tests. Now, can that be capped? I don't think so because insurance requires the doctor who's insured to say, well, I did everything. I thought of this, I thought of that, because otherwise he can get into trouble. It will be difficult to limit the number of procedures, but certainly you can be very sure that if you insist on putting it in the public domain, there'll be enough researchers, enough health bodies which will take out and say, so and so is taking the public for a ride. But if you don't even have even mortality data put out, you don't have anything to examine what's going on inside the hospital, there's no way that government can regulate. So this is my small answer.
Um, Thank you, ma'am. The second moderator question is from me. Ma'am, many questions have been raised about the pattern of admissions to medical colleges using NEET, and this is very important for public health, considering that the only examination that currently exists to allow doctors to qualify, to allow doctors to enter into medical healthcare is NEET. Now, NEET has been opposed on many grounds, such as that it establishes that it sources and funds a coaching industry. It is disadvantageous to children. It is disadvantageous to children who come from rural backgrounds, who do not have money to afford, coaching for NEET. Also, is a similar concern that there is a great divergence in the amount of syllabus that is covered by the state boards and the Central Board of Secondary Education. So, I would want to know your response on the homogenization of medical entrance tests and the cost or the benefit that it has on the medical professionals that come out in the field.
I would say that when you take everything into account, the most important thing is to have the best aspirants screened through an examination. You may, that usual cartoon which is shown by everybody, you have an elephant, you have a duck, you have a lion all standing in a row, and then you say, climb the tree. Well, we all know none of them can climb the tree, only the monkey can climb the tree. So, equality of opportunity is definitely very, very important. But I do feel that when it comes to the medical profession, you cannot really put down the requirement for showing that you have the ability to handle the kind of curriculum and the kind of pressure that medicine will require. And that is why meritocracy in the medical field is so very important. Because if you see the kind of training that good hospitals give to a medical student and the life they lead, you don't sleep for 36 hours at times when you are a resident. And you have to be imbibed. I remember some boy who was a roommate of my son telling me, Auntie, humko to phode ho jate hain sir mein. The kind of work you have to put in, the amount you have to absorb, the amount you have to regurgitate. And the fact is that if you have an examination which is well structured, you can definitely test who has the ability and the strength to be able to conquer something which is so difficult. Now, I think that you have to put that in position and look at the other side, which is, do you want to lower the common denominator so much that every villager, everybody has a chance to apply? You have done that to the IAS. It's exactly the same thing. 0.3% of all the applicants actually make it. But you've watered down the examination a lot already. And you've given the feeling to people that IAS aspirant home. So people for 3-4 years go around saying, I'm an IAS aspirant. It's the same thing. It's much more serious for medicine. IAS took head, it's power and glory for some people. But for medicine, it requires the ability to be so tenacious. Now, if you, I think, have to have a kind of a structure. After all, we all apply. I mean, our children, I'm sure you people will also apply for the SAT when you were in school, for the GRE, for the GMAT, for the CAT, and this, that. Why do you have these examinations then? If the whole world and his brother is to be capable of qualifying because they did not have good education, because they didn't have. Ultimately, what is your aim? Your aim is not to satisfy the largest number. Your aim is to have the best possible people to work as doctors. So I think I would not be able to say do away with NEET. NEET can be improved. It can be made differently. That's qualitative issues, which I don't think I'm equipped to go into, but it can be done. Many other ways can be there. Look at the USMLE and all those kinds of examinations also. Are we following those kinds of precepts? Are those the best? I don't know. But I do feel that for the time being, NEET is a better way of screening than having no screening at all and having these kinds of people, all of them aspiring for 40 different places and trying to get in.
Thank you, ma'am. I would call upon Ria to ask the next moderator question.
Thank you, ma'am, for that insightful answer. Now, my next question is centered around medical research. Like even during the pandemic, we heard of news like the Oxford is working on a vaccine for corona, but we never get to hear about AIMS working on corona or any other medical institute in India for that matter. So I want to know, why aren't we as indulged in medical research in our country as it is in the case of foreign countries? And also on that note, are government spending enough in terms of funds on medical research and to create the necessary environment which we need to facilitate medical research and to value it?
Excellent question. Thank you. I would have to be somewhat critical, Ria, not about your question, but in the answer I give. Because I have handled ICMR and looked at it when I was Joint Secretary, Additional Secretary in the Ministry. And in the pecking order of priorities, ICMR comes somewhere pretty low down. And the amount of money that is given in terms of, you might say, the size of the kitty is also not very significant. I would say that we have not invested. You need money. If you do research, you have to fund that research. If you don't fund it, how will you ever find people interested in doing medical research? Biomedical research requires a lot of, you might say, expenditure, not just on equipment and consumables, but also on patients, been recruiting them and keeping the data, statisticians. It's an expensive job. No, our governments have not invested. The state governments never do. And the central government does invest in research, but it is very, very small compared to our requirement. But within that, it's amazing that some solid medical papers have come out of our AIMS and ICMR. And that today only I read that CSIR has been able to probably do some sort of a finding that the strain of, and it's not my finding, it is something which is to be put into a published paper. So I'm just giving you an idea that at least they're working on it. That the strain of the COVID, which is in India, is probably somewhat weaker than experienced in other countries. It may not happen, it may not get published, but the fact that they're thinking of it means that there is some medical research of value going on. I also lastly want to say that when dengue was there about 3 years ago, 4 years ago, we had a very, very bad outbreak of dengue and everybody was scared. And I spoke to the doctor at AIMS who was doing the research. And I said, well, if Philippines can have sort of vaccine and they're able to use that immunization, why are we not able to? Why is India faltering on that? And the reply he gave to me was an eye opener. He said, Madam, there are about 4 strains and they change from year to year. And what happens in Philippines is not what happens in India. And the minute you bring it in the national program, everybody will want it. And it may, in fact, lead to more problems than solve. So he gave me such a cogent answer that I must say that if he had not been doing the research, I don't think that one can, and he was doing it without any great amount of funding. So people are still very committed to it, but I wholly agree with you that the amount of money given and the importance given and the recognition given is nowhere near what we need.
Thank you, ma'am. As the final moderator question, my question to you is about the my question to you is about the multiplicity of regulators that are present in the health sector. Right from the dismantling of the Medical Council of India and the establishment of National Medical Council, we have been told that regulation will be turned into enabling and facilitation. However, not just in the administration regime, but also in providing healthcare education, we find that there are a lot of regulators which in some way or the other hinder the capacity of medical students to explore their full potential. What is your take on the presence of regulators in the health sector, not just in the education field, but also in the regulation field? And how do you believe that these regulators can turn into facilitators and enablers?
Broad question, because what you are asking may not be what I'm replying, because you used a lot of phrases which themselves require definition. Be that as it may, let me say that I've seen Medical Council of India in its, you might say, full glory of corruption, and had to handle it also and battled so many things and probably often got into trouble over it also, because every time you stuck your neck out, you got into serious trouble with very, very important people who complain about you. And I do remember my work being taken away from me for 9 months and being told, even the chai wala would say, Abhi aapko kaam nahi diya hai sarkar ne. And the driver of my car saying, Abhi aapko kaam nahi diya hai. Because I was disgraced. I was told for 9 months I didn't do nothing because I had stood in the way of various, frankly, chief ministers who were pushing all kinds of medical colleges, and it was being aided and abetted by the MCI. But be that as it may, I can thank my lucky stars that I was at least allowed to continue in the ministry. I wasn't sacked. But to answer your question about the facilitation, I think these are all words and phrases which sound good and sound as though, everyone is being very helpful, very, very appreciative, very cooperative. But I think there is a hard difference between doing the right thing and overlooking the wrong thing. This is very, very serious stuff. And I would say that there's some things which should be absolutely zero tolerance. There's some things which should be non-negotiable. And you cannot have facilitation when it comes to standards. And I do feel that I don't know what the commission is going to do and what kind of people will man it and how they will look at the progress of medical colleges. But if the idea is to soft pedal the need for oversight, then I would say this is really the beginning of the end. If, however, it is to stop unnecessary meddling and fiddling and finding fault and all, which also MCI was doing, then I would welcome it. But I have not tasted the fruit of this decision, so it's difficult to say.
Well, thank you, ma'am. We've come to an end of the moderator questions. We'll now be taking preset questions, which are two in number. I'd like to call upon Ashutosh Chauhan to turn on his mic, preferably his video, and go ahead with his question. Ashutosh, you have the floor.
Thank you, Aditya. Thank you, ma'am, for the wonderful presentation and the lecture. My question was in relation to the Supreme Court now stating that healthcare is a fundamental right to every citizen in the country. Uh, don't you think that it is the time to that a center plays a much bigger role in ensuring that and shifting the healthcare from the state list to the concrete list?
I would say that some things need to go on the concurrent list, not entire healthcare. As you know, health is a state subject under the Constitution, and mercifully, that is a right decision, because in normal times, if you made it into a central responsibility, center would be doing nothing else but fighting. ये काम नहीं हुआ क्योंकि पैसा नहीं दिया. It's very much a state responsibility because it is your neighborhood, it is your district, it is your sub-center. So I don't think center should be playing a role in everything. What should, however, be done is, I hope you know that food and drugs are on the central list, and medical research is on the central list, and population is on the central list. Population means the funding of the population programs. I would say that public health is not on the concurrent list. It is only during epidemics that the center can step in. So I think public health should be put on the concurrent list so that there are more laws and requirements which are put in place, that states would have to have public health cadres. They would have to have people who are good at surveillance, who are able to do this kind of entomological work, zoonotic work, which are the kind of communicable diseases. Unfortunately, about 3 years ago, there was a report which was brought out which gave huge emphasis to non-communicable diseases, almost talking as though communicable diseases are over. I think that was a big mistake, because they said, oh, communicable diseases have come down from 80% to 30%. But 30% of India, dash it all, is millions of people. And if communicable diseases are there, then communication of communicable diseases continues. So you can't just say that now we have gone into NCD so we can do away with the communicable diseases. So therefore, I would answer you by saying public health should be on the concurrent list of the Constitution. Not everything in health should be on the concurrent list. Does that answer your question?
Yes, ma'am. Thank you.
Thank you, ma'am. For the next preset question, we have shortlisted Sanchali Chakraborty's question. I would request her to unmute her mic and ask the question. Sanchali, the floor is yours.
Thank you for your insight into the health system, ma'am. My question is that less than 20% of women in India have access to menstrual hygiene products, while talking about this issue still remains a taboo in most rural areas. And due to this, they're susceptible to various menstrual hygiene related diseases. What steps, according to you, can be taken to address this problem of awareness amongst the masses, considering that sexual education is often skipped or not discussed about in most schools, especially in the rural area?
You've raised a very, very important question, which I think, except for this movie Padman, nobody was even, it's not even, you might say, educated people refrain from mentioning this subject. And there was many taboos which still exist in rural areas, and all this business of you will not enter the kitchen and all kinds of things go on. I think that the whole area of menstrual hygiene requires behavior change communicators to be working to overcome this kind of taboo and myths which are prevalent. I'll give you an example of what I mean, which is different from the question you've asked, but related to it. When I was doing population stabilization for 3 years, I was the executive director of the National Population Stabilization Fund. That's been subsumed into the ministry now. I remember visiting abatement and Renubang in Gadchiroli, one of the poorest districts in Maharashtra, the poorest district, the tribal district. And I was taken by them to show, I mean, they gave me a person who worked for them who was like a Asha, to go to the homes of different village people. And they took me, and this woman took me to a village home, a small hut, which had two pieces of wood in front of it and a chappal, broken chappal. So I said, I didn't say anything, I saw it. I went inside and I saw this woman, very, very undernourished, sitting there with just a little lump next to her on the floor. And under that, there were a lot of flies on that filthy piece of cloth. And under that was a baby 2 days old. And the woman who was with me said that I will be able to give the injection because I'm allowed to give the injection for whatever that immunization is there. And this woman allowed her to do it. Came away. In the evening, I asked Rani Bang and Abe Bang, I said, all this, what is going on? All these sticks and chappal and this child under the dirty piece of cloth. So they said, look, please understand, these people have their myths and taboos. They feel that putting the sticks and the chappal is going to ward off evil spirits. So let them do it. It's not important. What is important is that that child was given that whatever immunization was necessary. And that is what we are after. And then they gave me the story of childbirth and how this very people, he said, we are working overtime to prevent the mother being held inside a kind of a cave for 40 days along with the child. At least now she's inside the hut. She used to be in a kind of a, almost like a toilet. She was stuck there with this child for 40 days. She was not allowed to come out. And because she was menstruating and all for whatever period it takes for that to stop, for the bleeding to stop, not menstruating, it's when after the childbirth. And the child was with her. She was shitting inside that place, urinating inside the place, and food used to be sent in a thali and pushed under some thing for her to eat. And Rani Bang said that is far more serious than the chappal and the sticks. Now, they had taken on themselves to educate these people that you must not allow this woman to be held in. That is the end of her and her child. What is important is she's in the house. But they said it's impossible to make them understand that that dirty piece of cloth should not be dirty. But we are trying. So I'm saying that when it comes to menstrual hygiene, you can imagine something as important as childbirth is treated like that, what they must be doing for menstrual hygiene. But who can overcome it? Only people who do behavior change. And they're not going to come from Mumbai or Delhi. They're going to come from the community. If an Asha is given this work or a second Asha is given this work, only a behavior change where it matters, I think that menstrual hygiene will be one of the most important things. At least the good news is that schools, girls' schools have to have toilets now. To some extent, NGOs have started making and giving sanitary pads made out of local material. And I think that is the first step. And the way they used to in the old days, family planning was always taught through showing a movie and then giving a message on family planning. I think Padman needs to be also, if not Padman, something on those lines needs to be shared. Because I think the taboos and myths are much more than anything else. What they do, whether they watch the cloth, whether they, observe hygiene, whether all the things that go with menstruation, those are things which can be taught to an individual. But can you teach a community which has a kind of a taboo against this? That is very important. And it's a very important question. It's not given the importance it deserves. I remember I was in a meeting of committee of secretaries when the top secretaries come and the cabinet secretary takes a meeting. And this woman came from the health ministry. I was not in health at that time. And she talked about menstrual hygiene and she raised this issue in the cabinet secretary's meeting. We're not doing enough. Something has to be told to the states to give primacy to this. And everybody in the room was so shocked and they said, have you got nothing else to talk about? This was the reaction among the top bureaucrats of the country. Fortunately, I'm talking about something that happened probably 20 years ago. So I hope things have changed now.
Thank you, ma'am, for answering the preset questions. We'll now be moving into the final set of questions, the audience questions. I'd like to request Ria to recognize the audience for asking the questions.
Thank you, Aditya. First, we'll recognize three questions from the audience. The questions will be in this order. First, Pranav will ask, then Siddharth, and then Srishti. Pranav, the floor is yours. Kindly unmute your mic and ask your question.
Thank you so much, ma'am, for such an insightful address. Ma'am, there have been, like, governments have been criticized for low spending on healthcare as a proportion of the GDP. So, will this crisis prove to be a catalyst for a substantial increase in the healthcare spending as a proportion of GDP? Thank you, ma'am.
It must. It simply must, because I think we are doing about 1.4 in this country, and even countries like Sri Lanka are spending 3.5, and our health policy wanted a much higher amount. We're nowhere near it. We're not even reaching out. They said at least for the time being 2.5, nowhere near that. The states are not spending enough. And I can only say that how does more money come? It comes by people shouting. When people make an issue, parliamentarians, MLAs start taking notice that it is becoming a public issue. It's becoming an election issue. And then they start badgering during parliament and during budget session to assign more money. I don't know whether that kind of public realization has come. Only lobbies get hurt, no matter which lobby it is, the automobile lobby or the lobbies for so many things, FMCG products and all that, all the concessions, this, that. People will lobby for something. And lobbies get heard because they are important. They're seen as vote banks also quite often. It's not just corruption, it's a question of also politics. When this becomes a political issue, the money will get assigned. It is not a political issue today. Nobody is holding anyone responsible for this state of affairs because COVID has come from outside, come and suddenly hit us. We're not looking, leave COVID. What about the rest of our health infrastructure? What about our primary health centers, our wellness centers? Okay, they're supposed to come, but how many have actually come? Are people getting the diagnostics that were promised? Are they getting it free of cost? Are people preferring to go to wellness centers as compared to private practitioners and RMPs? The real test would be RMP should have no work if your systems are working. That should be the test. I think these are the issues which public must raise, but public is too busy, too poor, too preoccupied with Roz ka ana jana to raise these issues and make it, as many countries have done, into a public health issue. And I've not been asked this question, but just because you are asking something very, very fundamental, I feel inclined to tell you that Canada, France, what do? You have to pay insurance, but the state does everything for everyone. You may be a top professor, you may be anybody, but you will be treated by the Canadian public health system or the French public health system, which you pay. If you earn so many francs, you pay that proportion. If you earn less, you pay that proportion. But you have your neighborhood GP and you have a system above that which goes up, and you have to be within that system. There are hardly any private people that you can go and sit and get. Yes, you can have private hospitals which are for the very rich, but the government takes responsibility for everything. And that is also very much what the NHS was doing, except that NHS was National Health Service of UK. It was a gold standard, but now it has really, really come down to nothing because they were starved of funds. I think that there is a need not just for money, but for also seeing what will be government's primary role. That to depend on insurance for everything is not the answer. There are many things which have to be done by the government, head on by the
Ma'am, do you mind if we take the next two questions in a bunch so that you can answer them collectively? Yeah. Ria, can you recognize the next two questions?
Yeah, so for the next two questions, we'll have Mr. Siddharth, and then after him, we'll have Ms. Srishti. So, Siddharth, the floor is yours. Kindly unmute yourself and ask the question.
Good afternoon, ma'am. Ma'am, my question is related slightly to the current pandemic. During this pandemic, various chief ministers of the states have been vocal about the lack of facilities, whether they be monetary or health facilities as such. There is a lack of deliverance from the center government, and due to this the state government has been unable to be efficient in handling the pandemic, and they've been saying that it is the center government who's not been sending funds and various health facilities. Is a lack of the center state coordination a reason for poor implementation of previous health schemes as well? And if yes, then how can we change this so that the benefits reaches the state level and more importantly to those who actually need it?
Another question?
Yes, ma'am. The second question, please.
Yeah,
Vice.
Srishti, please unmute yourself. Thank you.
Good afternoon, ma'am. My question to you is we witness the level of health awareness in India, which is pretty low and poor. However, at the same time, the healthcare services are costly, and for many, it is difficult to access. What strategies would would work irrespective of socioeconomic differences to improve and empower the ones responsible for their own health?
First, I would say that 80% the coordination in COVID between the center and the states has been excellent. I have been talking to health secretaries in Jharkhand, in Odisha, in Bihar, and none of them had complaints about the way the central government gave instructions and the way it also gave, the next steps and the protocols and things like that. I think in COVID, the fact that the districts got on track pretty quickly was also because of good cooperation and good coordination. I think the health minister was all the time on the video conference call with the health ministers of the states and the health secretary with the counterparts in the states. That is one side of it. Other side of it is a political side, and you know that um, if somebody does something wrong and is called out, then immediately it is treated as you're being unfair to us, kind of thing. Without knowing the circumstances, one can't really say whether the center was right or the state was right. It's very difficult to just give an omnibus reply to that. But I think if you look at COVID management on the whole, on the totality of it, the cooperation and coordination was quite extraordinary. And I think the systems that we have, the district management system, I'm not giving marks to the IAS, but I'm saying the All India services, the police, the CMHO, I mean, they're not all India services, but you have a Director General of Health Services, and then you have the state systems, you have the district CMHOs, and then you have the medical officers down. There is a system in place for administration, for health, for supply of food, for so many things. Other countries don't have this. So we have done extraordinarily well, and I'm willing to have an argument with anybody that looking at the scale of 730 districts and 30 states, the size of countries, we have done phenomenally well. And communication through video has been absolutely, from day one, they have been doing it. They were doing screening of passengers long before any lockdown even. I would say that that is full marks. Now, if some state is having too many fatalities or too many cases coming up and somebody blames them, the immediate reaction is to say that, well, what have you done to help us? So I think that your question is all right, but this would require a lot of data to be able to say who's right and who's wrong. But I think we should at this moment celebrate that on COVID, there has been tremendous cooperation and coordination. On other matters, no. I think that the fact that health is not given very much importance, I don't think I see the kind of coordination I saw in the 80s and 90s and early 2000s, which the National Health Mission, the National Rural Health Mission, there was tremendous coordination at that time, and much of this institutional deliveries, which were hardly 18% going up to 80%, has happened because there was this ownership for everything to do with maternal health, infant health, institutional delivery. And that was a shining example of coordination. I don't see that beyond that happening in the same way. And I would say that quite apart from Ayushman Bharat, which takes care of hospitalization only, you need much more to be done in the area of public health and preventive health. And I'll go on to the next question in the same breath, which is that what can be done? What can be done is to prevent ill health. It is not, it's unfashionable to talk of prevention. It is absolutely considered to be unglamorous to talk about something like promotion of health promotion. But that is the need, and that is not being done with the kind of, you might say, single-minded attention. And it doesn't cost very much compared to high-tech equipment and doctors and super specialists and beds and hospitals. It costs nothing to spend on being able to change lifestyles early and to make health into something that families and individuals own. The day that happens, you won't need the kind of, you might say, you won't see the turbulence in the health sector that we keep seeing all the time. You shouldn't be having people dying in hospitals, children dying, all kinds of things which happen apart from COVID. And also these very large cases of hypertension and of hypertension, diabetes. Of course, a lot of respiratory problems are because of very high levels of pollution. That is also health related and cannot be treated as somebody else's problem. It's an environment ministry problem. It is affecting health. And the doctors have been saying every winter that they've never seen the kind of condition in which patients are coming with respiratory distress, small children with asthma. It's all happening because of pollution. And that requires policies to be laid in place where you do not give car manufacturers and scooter dealers primacy over the fact that why is public transport not being given the primacy it deserves? Why should it not become absolutely impossible to use private transport, to park private transport? The day you make it unacceptable and unaffordable, you will find people will move to public transport, and public transport doesn't have to be run by public sector. You can contract it out, but it should be having a certain availability. And you will find that pollution will come down. The day pollution comes down, a lot of respiratory problems will also come down. So I've tried to answer both your questions, and I think this is something which is very worrisome because we have to take care of our lives, but how much can we do? We can't take care of the air that surrounds us. That is a government responsibility, and it must be owned by them.
Thank you, ma'am. For the final question of the day, we have Ishan Jain. Ishan, can you please unmute yourself and go ahead with your question?
Yes, ma'am. Okay, thank you, Aditya. Thank you, ma'am, for the insightful session. So, ma'am, my question is that we all have seen that how New Zealand as a country has countered COVID-19 and brilliant leadership of Jacinda, ma'am, who is the Prime Minister.
A little louder, I can't hear you.
Okay, ma'am, you can hear me now?
Yeah.
Okay, so ma'am, we've seen how wonderful leadership New Zealand has got and how Prime Minister of New Zealand has tackled the situation of COVID effectively. But ma'am, when we compare the situations of New Zealand and India, and we have seen a lot of media outlets praising New Zealand and not praising India in that sense, we see that New Zealand, the size of New Zealand is very much comparatively very like smaller states of India, and its per capita income is very much higher than India. So ma'am, how can we compare two nations so uneven with each other in the response to COVID-19 they have given?
No, we shouldn't. We should not be making comparisons at all with New Zealand. it's rubbish to do that. As I told you, we have populations which are the size of France and Germany and Italy. Rajasthan is the size of Italy's population. So it's ridiculous to be putting a poor country in the same basket as New Zealand or any of these. We can certainly compare with the United States, which is certainly the most prosperous country, and what a mess it's in. So I think that we have a lot to congratulate ourselves. And with very, very low resources, we were able to pull through for COVID. I don't say it's over. I don't say we won't have deaths, and I don't say that all is well. But whatever was to be done was done. And there was immense leadership, and it must be recognized and rejoiced that we had that leadership. So I would say that we should ever allow anyone to compare us. Whenever anyone compares, just throw at them the figures of what India's population is, and that will astound them. There is no way that you can compare.
Thank you, ma'am. To bring today's event to a closure, I would like to request Ravinandan sir for vote of thanks. Sir, the floor is yours.
Yeah, thank you. Thank you, ma'am, Shailaja. This was very wonderful, one of the most lucid and substantive talks that we have had in this series. I teach sociology here in the college, and one of the classic features when we begin to discuss India in the sociology of health and medicine classroom, this idea that there is a diminishing order between, medical service, as you put it, public health and preventive care. And by the time we come down to preventive care, it's, the story is over. You did it so wonderfully. You got that across to this, mixed audience so wonderfully. I also want you for your generous amount of time that you've given to us. It just has been a privilege to listen to you and the substantiations that you provided. Because I also have interest in the field, and my work covers certain aspects of sociology or health and medicine. I just it would take 1 minute to fortify what you said earlier. You're talking about the trauma centers, and I did field work in Benares. Very few people know. I mean, Benares is known as the spiritual capital of the country, which it is, but it's also a medical metropolis in North India, in Eastern UP, and partly because of the university hospital over there. So through the 2000s, I was doing field work there for my sociology study. And one of the interesting things that I noticed then was that, even emergency, the word that used to be very popular earlier, had become outdated. Trauma is the new word. So you have trauma centers all around Benares. And, the idea of emergency is no longer emergent enough. It's the trauma that has to be gotten across. And my mother asked, "What is this trauma? What does it mean? Why suddenly all the clinics, etc., have got trauma into their names?" And that forced me to think about it very seriously. And I, explored anthropological literature. And one anthropologist talks about this fact that how healing dramas have been so central in our modern lives. And that probably explains the reason why, we need to top up emergency with trauma, and trauma also perhaps would need another term, another adjective, because we have gotten hooked to this idea of healing trauma, doctors as legendary figures, heroes of our times, and so on and so forth. So thank you again. Sorry, I took more than a minute, maybe. Yeah. Thank you. I also want to thank our principal, Dr. Anu Srivastava, our vice principal, Dr. Reena Jain, and the director of IQAC, Dr. Shalini Suryanarayan, and the wonderful caucus team. Thank you very much.
Thank you very much.
Thank you so much, ma'am.
Thank you for having me. I've enjoyed
really
it.
great. And also, ma'am, principal has conveyed to me she had to leave the meeting a few minutes back, and she would like to thank you, and that it was a wonderful talk, and she expects you to join us soon, very soon on campus. I think Ravi sir would also agree with it that we
Yes,
would love to
absolutely.
host you
Yes,
sometime
yeah.
on the campus. And again, thank you, ma'am. Over to you, Aditya and Ria.
Thank you, Natik. Thank you, sir. Indeed, it was a great pleasure, ma'am, to host you. We expect you to hear from you soon in our campus. Also, the transcripts for today's talk would be shared via our social media handles. So please check out our handles on Facebook, Instagram, Twitter, and uh, follow us and share our content. Thank you very much, ma'am. Thank you, everyone, for attending.
I have a
Ma'am,
question.
sure, ma'am.
I would have loved to put up this on my own blog because I have a huge blog, and I thought that this is the first time that I have done a webinar with college students, and I was impressed at the level of your perception and your questions more than what I said. It was that you had thought things through, and it was remarkable that at this young age, if I think of myself at your age, I had no interest other than being on the stage. So I think that I was very, very impressed. And is it possible to get a link which I can put on my blog?
Sure, ma'am. Sure, ma'am. As soon as the transcripts are ready, we will share them with you so that you could post them on your blog. Also, this event is being streamed, live streamed via YouTube and Facebook. So we would also be providing to you the links for the same through which the recording of this meeting can be viewed.
How can YouTube capture your faces?
Ma'am, Zoom, the platform, has a facility to record every meeting, every conversation, and all the videos of the people that are being run.
It also automatically goes on YouTube, ma'am, and it gets stored on the cloud as well. So yes.
That's wonderful. Thank you so much. I've had a very nice morning and I did a lot of work because I kept in mind that I'm talking to students who probably know nothing. And then I felt completely shocked to know how much you actually know and care. Thank you.
Thank you very much, ma'am.
Thank you. Thank you so much, ma'am.
Thank you,
Oh,
Dr. Singh. That was very, very nice what you said. I enjoyed it.
Thank you. Thank you.
thank you, everyone. Over to the webmaster.